Hi, everyone. I'm Cheryl Thomas. I am the Strategic Initiative Officer at Stanford Sierra Youth and Families. My pronouns are she and her, and I am pleased to welcome you to today's webinar session, Resisting White Supremacy in the Workplace, Creating a Culture of Health for Sustainable Clinician Well-Being.
Perfect. Thank you so much. Thank you to those that joined us today. So today, some of our learning objectives include reviewing how burnout culture is perpetuated within mental health systems, all the systems that we work in, and learn how white supremacist values are masked as professionalism, and review and compile additional strategies for resisting white supremacist culture and sustaining a culture of well-being. So my hope is that today we could collectively create hopefully some resources. I'll share some resources that have been beneficial for me, but also know that we all are all experts in our own way, right? In our own experiences. So really welcome that sharing of resources amongst all of us here today. So first and foremost, I want to acknowledge current and past Ni Senen people whose indigenous land I presently inhabit. I'm currently in what is known now as Sacramento, and I'm coming to you all from a hotel room. Actually, I drove up here for an action that's happening, Safety Net for All, to support immigrant workers. So that's what I'm doing over here. But normally I come to you all from Dongba territory, which is presently known as Los Angeles. If you want to connect with me via email or Instagram or any other way, I also have an Indigenous Solidarity Toolkit that I'm able to share if you'd like to know how you can get involved in land back and reparation movements for Indigenous solidarity. So first and foremost, before I begin sharing the presentation, I also want to state my positionality, and I want to share a little bit about myself. So this is actually my mom and dad here, and we're actually from Guadalajara, Jalisco, Mexico, and we left Mexico in 1995 permanently and came to the US. But like 11 million other folks, many of us didn't have the opportunity to get a visa or to come to the US lawfully. There was no pathway, there was no line for us to get behind. So I grew up in California and witnessed my parents experience significant discrimination and exclusion throughout their lives. Something as simple as not being able to have a driver's license or be able to get access to a lot of the services that many of us present today provide. They simply didn't have that access. They also lived in rural California. We know that's also an additional barrier. And they only spoke Spanish, right? So a lot of providers are not equipped to provide that language accessibility and support. And so a lot of these experiences, witnessing the exclusion that my parents experienced, and then subsequently going through that myself, having been undocumented for 26 years, that really shaped my experiences. I also identify as queer and gender expansive. My pronouns are she, her, and ella. And all of these experiences, again, really made me think about the world and my worldview through this very intersectional lens, right? Experiencing things like racism and nationalism and cis heterosexism. And although I was experiencing moments of oppression, it was via my education that I also gained significant privilege. And now I that's one of my main goals, right? I'm able to use that privilege and knowledge that I gain both through my own lived experiences and incredible training that I've had the opportunity to have and get to share that information with folks. So this is actually me when the 45th president actually tried to end DACA. So that was a work permit that was available to undocumented folks. And myself and several friends took over the Capitol. I was currently in Wisconsin. pursuing my PhD, and we all showed up to resist that. So I've been very involved in organizing and advocacy as well outside of academia, and that's the lens that I come to you today with. Let's get into this topic, right, about burnout culture and clinician mental health and well-being. I think that this topic has always been a part, right, of our conversations. I remember going through training myself, and there was always a section, right, in our training, in some course about burnout. And it's a common term that we utilize, but I feel like it definitely got more attention as we navigated COVID-19 and the pandemic mental health crisis. So there's data that shows, and you'll see the citations here, psychologists reported significant increased requests for anxiety and depression treatment since the start of pandemic. So we were at the front lines, right? Really serving people. And as psychologists and mental health providers in general, saw higher referrals, right? We saw more folks coming to seek treatment. Other treatment areas with greater demand include sleep-wake concerns, obsessive compulsive and related concerns, and substance-related and addictive concerns as well. So we didn't just see that increase with anxiety and depression treatment since the start of the pandemic. Now, obviously, this increased demand for mental health services has contributed to clinician burnout. So we've seen this term, right, this experience come to the forefront. And there was actually significant worry, right, that there wouldn't be enough providers to meet the demand. But what we've known is that historically there hasn't been enough providers, period, right, whether there's been a pandemic or not, to meet the demands of mental health needs, right? So prior to the pandemic, 77% of counties were underserved and 55% of states had a serious shortage of child and adolescent psychiatry. So this is data that shows we already had a shortage, right, prior to the pandemic. And the study concluded that 43 of 50 states continue to report a severe shortage of mental health clinicians and psychiatrists. What is burnout, right? How has this been defined? How have we historically talked about this in our field? We've talked about burnout as being an individual issue, right? It's a clinician who becomes severely overwhelmed, maybe is being triggered, is starting to experience their own secondary mental health symptoms because of the work that they are doing, right? Or because they are overexerting, and this is what occurs, right? Or someone is significantly being exposed to vicarious or secondary trauma, right? It's very common amongst clinicians at work in trauma primarily. And so this is historically how we've defined and how we've thought about burnout, right? If folks have any other comments in the chat of ideas or thoughts that you've heard about burnout, please feel free to drop them in the chat now. But we've thought about it in a very personal way. And thank you, Kimberly. I just saw you put compassion fatigue. Absolutely. So in the personal level, this includes navigating ongoing personal trauma, right? So we're navigating our own traumatic experiences at home, right? And then we show up and do trauma work with patients. This could certainly lead to burnout. Inadequate prior training, right? This is also an issue that's been identified. I mentioned vicarious and secondary traumatization. People have always thought that perhaps there's an ability to prioritize personal well-being. Somebody in the chat just said a buildup of negative encounters, absolutely, and inability to regulate health. If you think of any others, again, put them in the chat. Well, the thing that I want to shift us towards and talk a little bit more about, yes, these things can absolutely contribute to burnout, but I think the conversation that is often missing is that burnout is very systemic. It's created by our overall health system and how we function as a field, right? That provides services to people, critical life-saving services to people. And so that's what I want to break down. So while the personal may absolutely have an impact, oftentimes I think focusing solely on the personal leads to blaming the individual and doesn't lead to creating changes that can actually be beneficial for organizations and for all mental health clinicians involved in different systems. So systemically, right, something that we've commonly seen among clinicians is that there's an imbalanced caseload. Folks are seeing a significant amount of clients and not having, right, a lot of time on their hands to do other things or engage in other work. Also, there could be things like organizational power dynamics, right? Who's making the calls, right? Who's saying, you get this caseload and you get this other caseload, right? Oppressive working environments. So sometimes being in settings, right? I didn't quite see that with folks who shared where you're coming to us from, but if you are in places that um, may be more oppressive, right? Like working in an immigration detention center or a hospital setting or a jail, right? That environment is also going to have an impact on us. Unhealthy modeling. This is huge. I don't know if you can reflect for yourself. I'll share what I've primarily seen is that oftentimes folks that are in leadership positions in some ways are addicted to work, right? And they make themselves busy all the time, don't make a lot of room for their personal well-being, for their own work-life balance, and oftentimes naturally expect other people to function the same way, right? Or maybe there's someone who's uncomfortable addressing um, conflict, or there's someone uncomfortable um, sharing their emotions, right? So these are forms of unhealthy modeling that lets people know that it's not okay for them to show up as their full selves. Again, conversations that we need to have, right? Um, a huge thing as well, and I'll go more in depth into that, is inadequate compensation. We do not value our clinicians the way we must. And also, there's oftentimes a lack of capacity building, right? So if folks don't have certain training, right, or aren't given certain tools, caseloads are so overloaded that there's no time for capacity building, right? How do we work as a team to support the well-being of us as clinicians and as an organization? And also lack of a supportive environment and valuing, right? Letting people know that they are valued, expressing gratitude for the work that they do. This is oftentimes, right, what leads to high turnover rates. So we're going to go a little bit more in depth into some of these. But again, I just want us to direct, right, our attention to the systemic, because that's the conversation we often don't have. Whenever an organization has a training on burnout, they focus on what the individual clinician can do and usually don't examine what can we do as an organization to create a culture of health, to sustain our clinician well-being, and to let clinicians know that they are valuable in the workplace and they are appreciated, and that you want to support their well-being and that of their families as well, right? That's not the standard way that we've done things. I want to read out what somebody else said. Shelley said, being expected to support others when we also were living with the pandemic, absolutely. Not being given time to tend to our personal challenges or needs. Yes, thank you so much for naming that. and also, right, experiencing things like discrimination, microaggressions, and insult. So how does colonialism impact our leadership, right? And the way that we do things within our mental health institutions and organizations. So many industries and institutions, including academia, right, including a lot of different sectors within mental health, were established on racist principles, including principles like eugenics, this idea that certain people are less than or are not up to par, right, with a certain standard. And that is literally what our field was built upon, right? Um, that we know that with the history of diagnosis and who historically would receive certain diagnosis, right? We know that there were ideologies of ableism, right, in which our DSM diagnosis manual was rooted in and founded in. And we need to talk about how this is related, right, to this conversation. Leaders and supervisors are oftentimes operating under the confines of white supremacist norms and policies. So for decades, right, we've just operated this way. This is the way we've done things because that's what's been passed down to us. That's literally how things have been done, and we've continued to do them that way. Yes, some things have shifted. Yes, some things have changed, but inherently, certain ways that we do things are oppressive, and we need to acknowledge that. So oftentimes we are operating under racist, sexist, heterosexist, cissexist, and classist ideologies that we have internalized about ourselves and also others. In 2022, 46% of employees said that discrimination was a problem in their workplace. So we know this, right? We know that this has been a problem, that this has been the norm. This is from employees outside of just mental health. This is in general. So we know that outside of our field, this is something that's a significant issue. And I thought this was huge also to be able to name intersectionality, right? So as we have these conversations about discrimination, we need to name that our transgender folks often experience the highest level of harassment, mistreatment, and violence in their workplace. So we have this data from the National Center for Transgender Equality, where they found that 90% of employees who are transgender have experienced this mistreatment. So huge, right? 90%, that's so significant. And I can tell you personally, I know so many friends who have left jobs and preferred to be unemployed literally because of how horrific the treatment they received from their employers was. One of the things that we need to name, right, is that I think people have tried to address some of these issues, especially as it pertains to discrimination, by talking about diversity, equity, and inclusion, right? That's become, I feel like, even more popular in the last 2 years as we experienced, this revolution with the murders of Ahmaud Arbery and Breonna Taylor, and several other folks, right? In the year 2020, a lot shifted for folks, right? And so people started to have more conversations about equity, diversity, and inclusion. But one of the things I think that we forget is that we are never going to be able to diversify ourselves out of white supremacy. So if we're not examining how the policies in which we engage in or the way that we do our work is inherently rooted in white supremacy, then we're never going to be able to reach the equity that we desire. So one of the things that I want to make clear is that these are assimilationist approaches. So I don't know, again, in the chat or in the reactions, if you could heart, I don't know how many of you have been exposed to Dr. Ibram Kendi's work, but he's the one who says this, right? That equity, diversity, and inclusion efforts often fail and don't meet the goal that they desire to reduce discrimination, to reduce these inequalities, because they simply are assimilationist approaches. So he says assimilationist refers to people who want you to assimilate to the racist system and its policies like they have. So oftentimes the standard is, well, this is the way I had to do it, so this is the way you should do it too, right? And that just gets passed down time and time again. And this is unfortunate, once again, because this centers the needs of individuals and a systemic reform versus a community effort and systemic abolishment. So we're not going to be able to um, tackle these issues if we're not going to community, if we're not going within, right, our own organizations and really addressing what the issues is, what is the problem, what is contributing to turnover or to clinician burnout or to dissatisfaction in the workplace. If we're not having those critical dialogues and taking that feedback seriously, then we are failing, right? We're failing as institutions and organizations. So the most prevalent type of discrimination charge is retaliation. I was actually shocked to see this myself. So whenever somebody tries to speak up, right, and say, hey, I'm experiencing discrimination in the workplace, right, or I'm being treated a particular way, folks are retaliated against. And this is actually the most prevalent type of discrimination charge. So this is data that shows that 55.80% of discrimination charges are actually retaliation charges. And I was actually surprised, but not at the same time to see this. It made sense, right? Whenever someone tries to report something in the workplace, you get the clapback, right? There's a lot of power that these institutions hold to keep us silent, to keep us in the same space. And thank you for those that are sharing that you've experienced that. And I have too. This is why I'm here. This is why I want to have this conversation. So retaliation occurs when an employee makes a complaint regarding discrimination or helps another employee assert a complaint of discrimination, and the employer retaliates against the employee for making a complaint. And this may look like firing the employee, demoting them, denying a promotion, decreasing pay, disciplining them. And sometimes it might be not so overt. And again, I'll share my experiences because of the way policies work in institutions. Sometimes the way that we experience retaliation is more subtle and there's no paper trail for it, and it's hard to explain to people, right? I don't know if this is resonating for anyone, but if anyone wants to share in the chat, please feel free to share, right, what you've experienced. So somebody did share in the chat, Ashley, thank you, said, it feels very powerless when you are up against a huge system. Absolutely, I'm right there with you. It made me question my own character and self as a person. Ashley, thank you for sharing. And you are not alone. I'm sure other people feel that way. Same exact thing happened to me when I tried to raise concerns. And we do it in such a respectful, kind, caring, loving way, expecting that something will change, right? We're hopeful to see something change. And then you kind of have the entire system turn against you. And what ends up happening, right? We question ourselves. We question whether we're wrong, or maybe we're not rooted in reality, right? Or whether we should have even said anything in the first place. And it's really, really exhausting. So again, how this ties to burnout, right? Is it burnout or is it systemic oppression? And that's what I want us to keep asking ourselves. So whenever someone does, right, express that they've experienced discrimination at work, it's commonly known as whistleblower. Again, I feel like this term has become more common in the last couple of years. And retaliation by an employer against a whistleblower is said to be protected by state and federal laws. So again, while it is said that there are federal and state laws that are in place to protect us, it's so difficult to prove, right? The policies itself require that there's all this documentation of it, right? And sometimes these things happen out of nowhere, right? Or in a private conversation where nobody else was there. And there's no way to prove that something happened, right? Or things are so subtle, as I mentioned, that it's really hard to prove things. So even though these policies and laws exist, my argument is that they are not enough, right? They are not enough because they're still not working. It's still not working, and people are still experiencing this kind of violence without getting the support that we need. I wanted to highlight this briefly. I won't spend too much time on it, but one of the problems as well with all of the things that I've been naming, right, with burnout and how do we address that, and what's the evidence-based way to address clinician mental health mental health burnout. The problem is that we're going to the wrong people, right? We're not evidence-based in terms of asking the folks that are people of color, right? Or LGBTQ, or at the margins in any way, right? Those aren't the people that we're asking what would be beneficial, right? How can we rectify this problem? So I don't know how many of you have heard of the weird problem. It pretty much demonstrates, the study found that 96% of behavioral clinical samples come from countries with only 12% of the world's population. And they tend to be populations that are white, educated, industrialized, rich, and democratic, which does not reflect the majority of the world and the majority of our experiences. So subsequently, this leads to poor treatment outcomes as a result. And that's the same for what's happening to clinicians. We're not actually addressing the issues, right? We want to say that we're evidence-based, but evidence-based for who? Who is this really for? I also want to remind us, right, that unfortunately we have lived in a society and have rooted ourselves in bad science, right? So not only is the evidence base on a certain population, right, but bad science has also been used to uphold and implement racist policies. So this is an image that I thought was important to share. Like, this is from real life, okay? So this photograph says some people are born to be a burden on the rest. Like, this is our history, right? This is what we were rooted in. And people have said that people have used science in the past to support white supremacist values, right? So in 1883, we had Sir Francis Galton, who first used the word eugenics to scientifically describe the biological improvement of genes in humans to establish racist concepts defined as being well-born. And eugenics drives today's policies in immigration, in health, in education, in housing, and economics. So again, to go back to my earlier point, right? Even while we try to create policies that say, hey, there's this policy that's here to protect you, right? We're still not addressing the systemic harm that continues to occur. And even those policies are not rooted in truly helping individuals or making it easy for people to be held accountable. It's still really difficult to go through that process. So I just thought it was important to remind ourselves that bad science is out there, that evidence base doesn't always include who we are talking about, right? Or in who we are needing to center and talk about. So we also need to be critical about, constantly trying to rely on an evidence base that maybe doesn't include the people that it needs to include. why is this important, right? One of my goals today is to encourage people to shift from normalizing the abuse that we experience as mental health clinicians in the field in general. Um, and again, Dr. Ibram Kendi's work talks about how he doesn't even use microaggression. I know someone put that in the chat. So he refuses to use the word microaggression. And again, I'll remind you, the term microaggression was coined within the field of psychology by Sue et al. And he says, I detest the post-racial platform that supported its sudden popularity. I detest its component parts, micro and aggression. A persistent daily low hum of racist abuse is not minor. I use the term abuse because aggression is not as exacting a term. Abuse accurately describes the action and its effects on people. Distress, anger, worry, depression, anxiety, pain, fatigue, and sometimes even suicide, right? So again, the reason why I'm sharing this is because I want us to be able to shift from this idea, right, that we're blaming the individual and not seeing all of these systemic abuses that are occurring that are contributing to our our lack of well-being, right? It's making us unwell, and we need to address that. Um, so one of the reasons why I really love Dr. Kendi's work is because he says it doesn't matter if you're Latinx or if you're Black or if you're white, any of us have the capacity to be racist in one moment and anti-racist the next. And it is our action, it is our literal actions that define whether we are being racist or anti-racist. And he says, obviously, these are supported by larger policies, right? So we're influenced by whatever the institutional policy is, right? That's telling us how to act or how to behave, what's okay and what's not okay. But it is still our actions that define where we are from moment to moment. So I just take his theory and I encourage us to expand that as well through an intersectional perspective. So I believe you could be sexist one moment and anti-sexist the next. You could be heterosexist in one moment and anti-heterosexist the next. Anti-sexist, right? The list goes on. Anti-ageist or ageist from one moment to the next. It all depends on our actions, right? So as we're working in organizations, we need to keep in mind people's intersectional experiences as well. So I want to say, and I think that point you're kind of probably getting that through what I've already been sharing, but it really begins with our training, and I think this is really unfortunate because while we're in training, right, it's very common, it's status quo that we're asked to provide our labor for free, right? So there's a normalized exploitation in our training and volunteerism, right? That you need to volunteer for this and you need to volunteer for that. And you need to do unpaid practicums, right? Who has the privilege to do that, right? Who has the ability to do that? I know somehow I made it work as someone who was undocumented and Latinx and queer and gender expansive. But that is a privilege to be able to do that, right? To be able to do something on a volunteer basis for many years to be able to get your degree. This inherently makes our degree programs inaccessible. This is also why we have the significant shortage in clinicians, because our training programs are not accessible to people. It's also normalized that we engage in a grind culture. So you have to be busy at all times, right? Volunteer for this other thing, do this opportunity and do the other opportunity. And so we are inherently institutionalized to contribute to this grind culture. And then as we're navigating all of this, we're critiqued, right? I don't know if anyone has experienced this. Again, show some emojis or share in the chat. How many of you have ever been critiqued for not having good work-life balance, or have been asked about your work-life balance, right? We're often told, right, that, well, we're so busy, we're doing all these things, we don't have good work-life balance. But yet, if we don't do these things, or if we say no to things, we're then critiqued for that, right? We're then told that we're doing something wrong. So clinician therapist shortage is fueled by inaccessible university and training programs, specifically for folks that are of low socioeconomic status, right? People who don't have, let's say, a caregiver who can support them through school, right? Or someone who's able to have some savings, right, that they could rely on. Not everyone's able to do that, right? So inherently it begins with our training, and we're already starting to normalize this kind of exclusion, and also normalize this work yourself to the bone mentality. And as I shared already, right, mental health providers are highly undervalued. I almost want to say, raise your hand if you feel like you've been undervalued. So the average salary for a mental health counselor in the United States is around $35,000 per year. And this is under the average monthly living expenses for a single person in the US, which is 38,266. And the average cost for a family of four per month is about $7,000, which would be $85,000 per year. And now we know the gap of salary earnings and cost of living is even larger in areas like Los Angeles. I know I live that truth, being in Tonga territory, and New York, right, or San Francisco. There are certain areas where we see that livable wage gap is much larger. Rupert et al. Found that the majority of moderately satisfied psychologists had poor professional and personal life balances and felt little sense of control in their work environments. So what this data shows is that people who felt like they were okay, they're semi-satisfied, they felt like one of the biggest problems that they encountered was not being able to have this work-life balance, and that they didn't have control of their own schedules, what their life looked like, right, in work. So again, really, really important to keep in mind what contributes to this dissatisfaction. But I think the wage part is a conversation that we often don't have. So I just wanted to take some time and share a little bit about some recent experiences that I had that also inspired me to have this conversation. And I hope that we continue to have these kind of conversations and push back, right, on the status quo. So I was at the latter end of my training in recent years. I'm going to keep things anonymous as much as I can. But I noticed that I had a 50% clinical training fellowship, and the rest was other work that I was supposed to be doing. But it came to my attention, I noticed that I was also always being given clients who literally nobody else felt like they could work with. They would describe them as difficult or challenging clients. So that was the first thing that I started to notice. And then I noticed that even though I was a 50% clinician, that's where 50% of my time needed to go. I had double the people on my caseload than the people that had 100% clinical fellowship. I had double the clients. And when I realized this, I also noticed I had already been reflecting and realized that I wasn't given the professional development time that I was promised. I wasn't being given the ability to do immigration evals like that had been promised to me. I wasn't being given any research time. So essentially, they were filling up any of my empty slots with clients. And when I gently tried to raise this concern, first of all, there was already a problematic dynamic. I had two white queer supervisors at once. So these two people would meet with me at the same time, which I don't know how many of you have had that dynamic, but that is an enormous dynamic. Usually, when we do clinical supervision, you have one supervisor, right? You're not consistently meeting with two supervisors. So that was the experience I was having. And when I brought this up, right, when I brought up, hey, I'm wondering if I cannot get any more clients because I noticed that I have more clients than everyone else. And I am also not getting this time and that time, and I'm not able to do research because I'm not meeting my goals for my fellowship, essentially, because everything, my caseload is just being filled up, right? And when I brought this up, my supervisor's response to me was I was totally gaslighted and was told, well, maybe you're not managing your time with patients effectively. And it became a questioning of what I was doing at every hour of my week. And they literally had me send them my schedule and lay out what am I doing at this hour and what am I doing at that hour. And their conclusion was that I was probably spending too much time thinking about my clients and that they noticed that I care too much. They literally said that I care too much about my clients. And they wanted to meet to review and talk about what we could do with my schedule. And they said that my research time needed to happen at another time, that unfortunately, they don't even have the time to do research. So I have to moonlight and get a separate opportunity to fulfill the opportunities that were promised to me when I took this position. But this was my experience. It immediately switched around. It became a, well, you're doing something wrong. You must be spending too much time on clinical work, and that's why you don't have time to do these other activities, right? There was no accountability for how they were contributing to this, right? And it turned into um, I was lacking the ability to manage my caseload, right? And they even mentioned, well, maybe you're experiencing burnout. Is that what you're experiencing? Is it burnout? Is it that we're giving you um, that you're not able to manage your emotions related to the caseload that you have? When I was very clear about the problems, right? So there was no room to go back and forth. And one of the things that I have found time and time and time again is that it's often the folks that tout that they are trauma informed experts. So they're the ones training other people on doing trauma informed care. They are often the ones inculcating that trauma within their own organizations and within their own institutions. So I had this other experience where there were two clinicians that had asked to be off maybe like months prior, and I had agreed to step in and cover them. But then that day happened to land on my wife's master's graduation, and I requested to be off. It was just 1 hour. I was covering 1 hour of the other clinicians. So it was a group that we conducted, and there was always a supervisor who would supervise the clinicians doing the group. And so that supervisor mentioned that they were going to be there all day. So they're a licensed clinician, they're the founder of the group, and I asked myself, wait a minute, why do I need to be there, right? Why do I need to be present if this person can cover the group themselves, right, and facilitate the group? And so I contacted that supervisor. We used to just be able to request time off via text message. And she was like, oh, well, you know what? Yeah, go ahead and take that day off. If you can't, make it work, if this is the only option that we have, we'll postpone the group for that week. And I was almost shocked. I was like, wow, I can't believe she suggested that. I was really happy. I made plans, right? I was so excited that I could be there for my wife. And the next Monday, so that was on Friday, on Monday, still 2 days before the group, they came to me and said that they couldn't accommodate that anymore and that they had made a mistake. So it pretty much turned into this back and forth email exchange because I had said, right, I'm going to be there for my wife's graduation. She had just lost her mother to cancer. And I thought they would know and recognize the significance of this, right? And I shared it in the email. Huge mistake. Because it ended up coming back to me, right? They actually CC'd the director and made it seem as though I like was truant and didn't show up right to work, but I had had an approval. I had had an approval to be off that day, right? And when I spoke to the supervisor, I also shared these other dynamics that I'd been experiencing at work. And it was shocking what she said, right? She said, instead of like, hey, would you like to have a mediation meeting or how can I support you with the situation? She said, um, the university is going to have this person's back. So I just need to know if you want to end your fellowship early or not. So it was almost like forcing me out the door, right? And so it was really, again, just an example of how these things happen so subtly and in private, oftentimes, right? And you're not able to do much. And again, how the clinician is blamed, right, for being unprofessional or not meeting the needs of whatever, but we're actually being forced, right? And in these violent dynamics that we need to disrupt. So I wanted to share this model. I'm aware we have about 10 minutes left. That's what I'm getting in the chat. So these are ways in which we uphold colonialist, capitalistic, and white supremacist leadership, right? So we often separate the personal from the professional, and we treat humans like machines. We also uphold unrealistic perfectionist expectations versus acknowledging the needs and strengths of others. And we also force a lot of deadlines, right? Versus prioritizing well being. Sometimes some things can be pushed back if it's not prioritizing someone's well being. And then rejecting interpersonal feedback and becoming defensive, right? Like in the experience that I shared, instead of leaning into understanding, right? What is the impact? How am I impacting you right now? And what can I do to support you? And also dictating, right? Dictating how meetings go instead of creating spaces to process and we request input from others. So, one of the ways that I feel like we could begin to challenge this is to use this tool, this amazing work by Daniel Buford, and but this is one of the tools that I wanted to give to you all as part of our conversation today that I feel has been really helpful for me in figuring out how do we identify this is white supremacy, right? This is what's happening. And what I love about the document is that it gives you an antidote. So it literally walks through how do we challenge perfectionism? So there's an antidote there. How do we control for a sense of urgency? How do we challenge defensiveness in the workplace? How do we challenge this mentality of quantity over quality, right? This is huge. We're dealing with people's mental well being. It should be a quality, right? How do we provide quality care to people that truly heals them and helps them feel better? Some ideas for how we can begin to shift towards prioritizing a culture of health, right? A culture in which our health as clinicians is valued, is recognized, is centered, is celebrated. So we need to stop saying and using the term provider burnout, because hopefully after today, you could see that there's so much more going on. This blames the individual instead of examining the system and lack of systemic support. And it immediately rids organizations and leaders of responsibility and accountability. When raising of concern is met with blame and critique, obviously there's going to be hostility. We need to provide spaces to process real life things. I think this is significant to a culture of health. Whenever there's political, social, or pandemic related stressors or stressors in general in our lives, we should have a space in the workplace where we could talk about that. This creates engagement, this creates connection amongst our peers, amongst our colleagues. And also, we need to encourage responsiveness, right, to feedback instead of this fearful, defensive response. It doesn't help us, right? We can also set more realistic work plans. I'm a consultant, so I get to help people with a lot of this. I get to help organizations work directly on this. So oftentimes people will hand out these inequitable work plans, but we don't ask people for feedback, right? Until it's too late and we realize, oh, we overplanned. Oh, that was an unrealistic work plan. So this prevents us from, again, blaming the individual and instead working alongside our colleagues to figure out better work plans that support our well-being. We also want to build in group wellness activities and opportunities to connect. So filling up people's caseloads obviously is not going to support that. And create, right? If you need to get a consultant to help you to create a system of accountability, we are going to hurt people. We are humans with different experiences where we come from different walks of life. So it's inevitable, right, that we are going to hurt people. What kind of system do we have in place to hold people accountable when harm happens? And how do we engage that in a horizontal way across all folks in the organization, right? How do we disrupt this vertical way of doing things within organizations? So examining these policies, right, that are rooted in white supremacy is critical. Hopefully you could use this document to start some of that critical analysis if you haven't already done that. And also, like I said, bring consultants in when it's necessary. Sometimes it's really difficult to do the work from within. That's what I found. That's actually why I became a consultant. I found it to be really difficult to work from within the system. But when you have someone else being able to provide insight, name patterns, and work directly on solutions, that can be really beneficial. What I will also leave you with is some guiding questions for how you can create and sustain a culture of health. So I'll read them. How am I disrupting suffered leadership? The model I shared earlier. Is my leadership providing healing, empowerment, support, and love to others? How and who is holding me accountable? And I have this. I have friends that I call and I'm like, I did this thing, I said this thing, I noticed some reactions. Please check me. What am I missing? We need people in our lives that hold us accountable, right? We're not immune to this either. How am I supporting my own self-care and healing to prevent reperpetuating cycles of harm and trauma? So the work is personal. It also starts with us, right? We've learned this. We need to unlearn it and reclaim something new. How am I ensuring my own ongoing learning and growth? How am I centering love, justice, and liberation for myself and others as I do this work? And how am I actively answering the calls to lean in when we are asked to lean in and create room for ongoing collective processing and co-learning? And the reason why I highlight these guiding questions is because of liberation, right? Just like Lila Watson said, if you have come to help me, you are wasting your time. But if you realize that your liberation is bound up with mine, if one person's not free, no one is free. right? But we can work together on this. We can work to dismantle these white supremacist ideologies and create a culture of health. It is absolutely possible. I've seen it done. I've been able to work with people to help them make this happen. It is a lot of work, but it's possible, and we deserve better, right? We deserve better. And this is how you can get in contact with me if you'd like to connect or learn more about some of the information that I shared today. Thank you, everyone, for being here.